isn't a specific. Okay, so generally there isn't a specific source for blood loss and iron loss in males. So that's generally why the numbers are a bit higher here than they would be in adult females. And now there are also different numbers from 2 years to puberty. Less than 11 grams per deciliter is considered anemia. But for example, in adult males, less than 13.5 grams. So again, these are reference values that will usually be provided for you in the question, but that's just important to keep in mind. In newborns, for example, less than 14 grams per deciliter. So you can't just say, like, let's say I got you someone who's, let's say, hemoglobin levels are 12. Well, if they were 12, for, let's say, an adult male, that would be considered anemia, you know? For a newborn, that would be considered anemia, but for, let's say, an adult female, that would be considered normal. So that's why we really need to keep these two factors into account, and Dr. Rehan usually stresses on that as well. Okay, so now let's look at the physical signs of anemia. Again, as a doctor, for the most part, you will be ordering complete blood counts or CBCs, and we'll talk about that in a second. But there are signs of anemia that you can tell by just looking at the patient. One of them is pallor, and this, again, is non-specific. It just means pale conjunctiva, and I'm going to show you what that looks like in a second. You can also see that on the palms of the hand. Sometimes it's super red, which is what we call, you know, if you have redness on the palm, but if it's very pale, we could consider that pallor. Okay, and you could see it again on the conjunctiva of the eye, but I'll show you how that looks in a second. Another one is angular stomatitis, which is when you have inflammation at the corners of the lips. It's non-specific, however, you see it more with vitamin B12 and folate deficiencies, which are megaloblastic anemias. Again, if I'm bringing up terms that aren't familiar, we're going to get through them in a second, okay? Then you have jaundice, or in other medical terms, you can say scleral icterus, which is the yellowing of the eyes. You can also have yellowing of the skin. And this is more specific to hemolytic anemia, which we're going to talk about later in the lecture. Then you have something called colonychia. Again, I'm going to show you this in a second. But colonychia means spoon-shaped nails, okay? And this is specific to iron deficiency anemia, more than the other types of anemias. Okay, and you can also see leg ulcers in sickle cell anemia. That's because in sickle cell, you know how the cells are sickled, so they can get caught in tiny blood vessels in the leg, and that can cause ulcers, and it can be very painful for the patient. Okay, but again, even if you see all of these, let's say you see someone with pallor and jaundice, for example, you can't just 100% go and say, okay, this person has hemolytic anemia. You need to do further studies, and we're going to talk about those in a moment, okay? But just for the physical signs, so I'm not sure if you guys took it in pro yet, but when you are examining the conjunctiva for pallor, you're not looking at this little rim here. That's why they tell you you have to lift the eyes down of the patient, because you need to see this part. Usually it's red, okay? But when we say pale conjunctiva, this is the part that's going to be pale. It's not going to be this whitish line here, okay? So just keep that in mind. And this is the colonychia that I was mentioning, or the spoon-shaped nails. That's more specific to iron deficiency anemia. This is angular stomatitis. So you see how it's inflammation at the corners of the mouth here and here. And this is jaundice. But this specifically we call scleral icterus. Okay. So scleral being the sclera of your eye and icterus meaning yellowing. Okay. So this is specific to hemolytic anemia. Of course, you don't only see it in hemolytic anemia. It's present in a lot of other diseases, but of the anemias, that's what it would point towards. Okay. So I mentioned that you saw a patient, for example, with these physical exam findings. You don't just say, okay, this person has anemia, let's call it a day. Of course, you need to do further investigations. And the most important is going to be our CBC, or complete blood count. And Dr. Rehan had an image of this in his lecture. So what it shows is it shows all the different values we look for. Red blood cells, white blood cells, platelets, hemoglobin, hematocrit, and a lot of these things we're going to be talking about in more detail. So that's the first thing. Why? Because you want to look for the hemoglobin levels, right? Because we said anemia is low hemoglobin and hematocrit for age and gender. So if those two meet the criteria, then you can say, okay, we have a problem. Let's figure out what type of anemia this person has, okay? And that's when we go into our second line investigations. Maybe if we're suspecting an abnormality, let's say like thalassemia, we could do hemoglobin electrophoresis or sickle cell. There's iron studies that are going to become important that we'll talk about in a second. Vitamin B12, folate, bone marrow examination. So these are all second line investigations, okay, that we look into after confirming that the patient has anemia. So now let's understand what hematocrit is, okay? So hematocrit is our mean cell volume times the number of red blood cells we have. So what does that mean, okay? We call it packed cell volume, which is basically, if you look at this, so we basically took a blood sample and then we centrifuged it or spun it around a bunch of times until all of the layers separated. So the hematocrit is talking about specifically the red blood cells that are here. Okay, you have other things that like the buffy coat, the plasma that has proteins, etc., etc. Okay, so what we're multiplying is the mean cell volume times the RBCs. So the RBCs is just the number of red blood cells that are there. And the mean cell volume is very important, and I need you guys to memorize this range, okay? So what it means by its name, the mean cell volume. So how big is each red blood cell on average? And so the normal range is 80 to 100 FL. Okay, and I need you to remember this because any anemia within this range, we're going to call normocytic, meaning the cell size is normal. Anything less than 80, we call microcytic, micro meaning small, cytic referring to cells, so small cells. And greater than 100 is going to be macrocytic, meaning macro meaning large, cytic again referring to cells, so large cells. And this is going to become very important because this is how we're going to classify anemias, and that's the basis of our entire lecture. Okay, so just remember our mean cell volume is the average size of red blood cells. Normal range is from 80 to 100 FL. Okay, anything less is microcytic, anything more is macrocytic. So again, if we're looking at the hematocrit, this is in a normal person's blood. In anemia, we have very little, right? We said low hemoglobin and hematocrit for age and gender. So here it's much less, and you have a lot more plasma volume that's containing the tube here. So that shows you that there's less than normal. Polycythemia, on the other hand, is the opposite. So you have more red blood cells than normal and an elevated hematocrit. So hematocrit are red blood cells. So hematocrit is basically the mass of the red blood cells. So this is, let's say we took a sample of blood, we spun it around for the elements to separate, and this, the number of red blood cells that are present here times the mean cell volume or the average size of our RBCs, that's what makes up our hematocrit. Okay. In polycythemia, would precursors be high? Yes, they would, but I'm going to talk about that later. For now, I just want you guys to understand the concept of what hematocrit is. It's just the clump of red blood cells. How do we measure that? Okay. Or on average, how condensed are our RBCs? Does that make sense for everyone? Before we move on. Yep, easy. Inshallah. Okay. If you guys have any questions, just feel free to ask me, don't worry. So now let's go back to what I told you guys about the different sizes. Remember, our range was 80 to 100, which is what we call normocytic. So our normal RBCs, this is a normal person, they have normal amount of blood, normal amount of hemoglobin, right? Normal hematocrit. But let's say they have low hemoglobin, okay, low hematocrit. Then we need to look at what are the sizes of our cells. So between 80 to 100 is normal, so that's what we call normocytic anemia. We said less than 80 is microcytic anemia, so the sizes of these cells are going to be smaller than normal. And greater than 100 is what we call a macrocytic anemia. So this is, again, what we talked about. I just wanted to show you guys visually what that would look like. And so let's look at it in pictures of blood smears so you guys see the difference. So these are our normal RBCs, okay? And in low MCV, they're less than 80. So you see how this cell, for example, this red blood cell is smaller, this is smaller. But if you look on the other end, these cells are much bigger than the ones in the middle for comparison. So this we would consider macrocytic, right? So this is microcytic, less than 80, smaller cells. Normocytic would be 80 to 100, okay? And macrocytic would be greater than 100. So for the most part, they will give you these numbers. You wouldn't just be expected to look at a red, let's say a blood smear and just assume that all of these are normal. Okay, so just keep that in mind as well. So Now we talked about that. Now let's talk about the next thing that's important, which is the mean cell hemoglobin, right? So the mean cell hemoglobin, let's just look at the name and break it down because it's going to tell you the meaning. Mean meaning average, cell meaning inside the red blood cells, and hemoglobin referring to hemoglobin. So the average amount of hemoglobin in each red blood cell. Okay, so the way we refer to it in hematologic terms is the weight of hemoglobin in the average red blood cell. Okay, and the normal range for this is 26 to 34 picograms, and this they should usually give you in the question. But the important thing is that, let's say if you have a normal amount of hemoglobin, the red blood cell is going to appear red. It's going to appear normal. So let's say this one here, for example. Okay, but if you have, oops, sorry, thought about the animations. But if you have less hemoglobin than normal, okay, less hemoglobin in one single average RBC, what's going to happen is you have this central area of pallor, okay, or this pale area in the middle of the red blood cell gets much paler. Why? Because there's no hemoglobin there to give the red blood cell its red color. Okay, so this is what we call a hypochromic anemia. Hypo referring to less, chromic referring here to color, okay, or the pallor. So you have less color or less hemoglobin than normal, okay? And so what this is going to differentiate is hypochromic and normochromic anemias. So normochromic meaning the amount of hemoglobin in each cell is normal, okay? Hypochromic means the hemoglobin or the amount of hemoglobin in each cell is less than normal. That's why we have this central ring of pallor, right? And so if we take this mean cell hemoglobin, its standard deviation is going to be the real cell distribution width or the RDW. And we'll talk about that in a second. Okay, but just to recap, we talked first about the hematocrit, right? And the amount of hemoglobin. And then we said our normal range is going to be here, let me just open it for you guys. Our normal range is going to be 80 to 100. Less than 80 is microcytic. More than 100 is macrocytic. In the middle is normocytic. And for these mean cell volume, okay, so this is just showing you the example of the MCV. Low is less than 80. This is exactly what we talked about, right? And then after that, we talked about the normocytic, macrocytic. We talked about the mean cell hemoglobin or the average weight of hemoglobin in the average RBC. Okay, so hypochromic meaning you have less hemoglobin than normal in one red blood cell, which means we're going to have this central area of pallor. Okay, and then we have normochromic, which means you have a normal amount of hemoglobin. Deal so far? Everyone got that? Inshallah. Yep. Okay. Awesome. So now, after understanding those two concepts, we said the mean cell hemoglobin, or MCH, which we just talked about, has a standard deviation, or basically when you distribute it, that's what we call the red cell distribution width. So what does this mean? I know it sounds kind of weird and the name is long, but all it's telling you is how different are the sizes of these different red blood cells. Okay, so for example, you have this iron deficiency anemia and thalassemia minor. Okay, in iron deficiency anemia, you have less hemoglobin in each cell. Okay, however, do you see how the different cells have different shapes? This is what we call a different sizes, sorry, different sizes. So for example, this one's a bit smaller than this one. This one has a different shape. This one has a different shape, for example. So the different sizes we call anisocytosis, okay? So an meaning without, iso meaning the same, cytosis referring to the cells. So the cells are not the same or they're different sizes, okay? Poikilocytosis is when you have different shapes, but we'll talk about that later, okay? So when you have difference in the sizes of the RBCs, okay, that's called anisocytosis. So in iron deficiency anemia, you have a very big difference in the different in the sizes of the RBCs, and so it has a very high red cell distribution width. Okay. However, in thalassemia minor, we'll talk about it briefly later on, but thalassemia is a genetic condition. And so the problem that's in one cell is the problem that's in all the cells. And so although they're all, again, hypochromic, microcytic, their sizes are relatively the same, which is why we call it, or we say it has a low RDW. Okay, I'm going to repeat that. Mean cell MCH has only hemoglobin. Yeah, so when we're talking about the mean cell hemoglobin, it's only the amount of hemoglobin in one cell. And we divide that into either normal chromic or hypochromic. Hello, but just again, I'll repeat for the RDW. So RDW is the difference in sizes between different RBCs, okay? So if you have a lot of different sizes, for example, here we see a lot of different sizes of RBCs, so we can see anisocytosis in this blood stream, okay? In iron deficiency anemia, the difference in sizes is very severe, okay? So that leads to a high red cell distribution width, which tells you the sizes of all of these cells are different. However, in other conditions, such as thalassemia minor, this is also a microcytic hyperchromic anemia, but the red cell distribution width is low, which tells you that all the cells, give or take, look the same or are the same size. Okay, does that make sense to everyone? Yep, I hope so. Okay, so just to go over it one more time, when we are looking at the mean cell hemoglobin, this tells you how much hemoglobin is in each single cell, right? Hemoglobin gives the cell its color, or the red blood cell specifically. So if you have less mean cell hemoglobin, that tells you there's less hemoglobin in the cell, okay? And so you can see there's not as much color. There's a central area of pallor here versus the other ones, okay? So that's what we call hypochromic, so less color, okay? And if we take this and we distribute it, now we want to see, okay, we know that there's less hemoglobin in the cell. However, are all the cells the same size? If they are all the same size, then the RDW is going to be low, okay? So that's, for example, in thalassemia. You see how all of these cells are almost the same size. However, in iron deficiency anemia, the cell sizes are going to be very different, which is what we call anisocytosis. The cells are not the same size, okay? And the RDW is high. So I just really want you to hammer in that in iron deficiency anemia, RDW is high. In thalassemia minor, RDW is going to be very low. Okay, I hope that helps. Does that answer your question, Samir? Okay, great. So now let's move on to the next thing, which is reticulocyte count in percentage. So what reticulocytes are, these are the red blood cell precursors, which is, one of you guys asked a question earlier, which is in polycythemia. So we're going to talk about that now. So so basically red blood cells don't come from nothing. And you guys took another lecture on this with Dr. Rehan, I believe. So normally reticulocytes are between 0.2 to 2%, okay? If you have a very, very high count of reticulocytes, that tells you that there's a lot of cells being made, okay? So that tells you that there's a high count of reticulocytes or high count of RBC precursors for one reason or another, okay? And when you have a high count of RBCs, that's called polychromasia, okay? So poly meaning more, chromasia referring again usually to color. But in this case, there's a specific stain that's used for the reticulocytes, and you can see that here. So this is telling you that these are reticulocytes, remember, because it stains for the DNA, because remember that reticulocytes have DNA and then they lose their DNA and then they become RBCs, right? So high reticulocyte count, again, is called polychromasia, referring to more chrome or color, which is because they have DNA. Okay, and usually it's between 0.2 to 2%. It can be high in certain conditions such as hemolytic anemias. Yes, the supravital stain. Thank you, Mashad. Yeah, so again, that's just the basic concept here. So now we go to the actual chunk of this lecture. I know I was a bit slow in the beginning. I just want to make sure that you guys, every single person just has that hammered in. Okay. And now, based on what we just learned, we're going to classify anemias. There's two different ways to do it. You can either classify it according to the underlying mechanism, or you can classify according to the morphology. Okay, morphology means shape. So that's what we were talking about. Your anemias can either be normocytic, normochromic, they can either be microcytic, hypochromic, or they can be macrocytic, and usually that's normochromic as well. Okay, so for macrocytic anemias, those would be, for example, megaloblastic anemias, which is vitamin B12 or folate deficiency. Folate is vitamin B9, by the way, if you guys forgot. Uh, Normocytic normochromic would be due to blood loss, and it can also be seen in renal failure. Okay. And then microcytic hypochromic is going to be seen in iron deficiency anemia, thalassemia, and anemia of chronic diseases. We're going to go into these in detail in a second. Okay. So that's how we classify according to the morphology, and that's usually how it's going to go in the questions that you guys get in MCQs. Now, for underlying mechanism, it can be either hyperproliferative, meaning you're increasing the turnover of red blood cells in hemolytic anemias. And in the underlying mechanism, which would be, for example, acute or chronic. If it's acute, for example, someone had a surgery, they lost a lot of blood, someone got into an accident, they lost a lot of blood. Chronic could be GI bleeds. So if someone has colon cancer, for example, and they're bleeding, that could be an underlying cause. Menorrhagia, which is when you have very heavy menstrual bleeding. Then you have hypoproliferative. Okay, so hypoproliferative meaning you're not proliferating as much. This could be nutritional, for example, iron deficiency anemias. It could be due to inflammation. It could also be due to renal failure, and a specific cause that's important is going to be aplastic anemia. So again, you're going to divide anemias based on either the morphology, so either how it looks or what the cause was. So now first we have anemia of blood loss. When you lose blood, let's say someone got into an accident and started bleeding. So if it's acute, or someone had a surgery and they started bleeding, acutely, your hemoglobin is still normal. If you take a blood sample from this patient that came into the ER, just came from an accident, usually if you take it, it's going to be normal because it takes a long time for the hemoglobin and the hematocrit to actually drop. And that's why hemoglobin is normal for the most part, and reticulocytes are seen in the blood after 2 to 3 days. It's not like you start bleeding and they just immediately come out of the bone marrow. But chronic blood loss causes iron deficiency anemia. So an important clinical scenario they could get you is, let's say, a postmenopausal female. So she stopped menstruating, there's no cause of her blood loss, presents with iron deficiency anemia. Or an elderly male presenting with iron deficiency anemia. Why would that make you think of something weird? Because GI bleeding is an important cause. So that could tell you maybe this patient has a cancer in the colon and is bleeding into the stool, and over time that's going to cause an iron deficiency anemia because they're losing iron. Okay, so that's anemia of blood loss, and that's how it's generally classified. Then we go into the hypoproliferative anemias. Hypo meaning you can't proliferate, you can't make red blood cells. There's a problem in the early steps, whether it's with the heme, whether it's with the globin, whether it's with the iron, whether it's with the cells themselves, maybe there are no precursors. So there's something in the beginning phase of making these cells that's making you unable to produce erythrocytes. The important thing here is that the reticulocyte count is going to be low. Why? Because you can't make reticulocytes in the first place to be able to make other cells. Okay, so examples of this would be nutritional, which would be iron deficiency anemia, acute and chronic inflammation, cancers like, let's say, leukemia, renal failure, and aplastic anemia. And aplastic anemia we'll talk about in a second. So for microcytic anemia specifically, I just want you to keep in mind, you have loss of either heme, globin, or protoporphyrin. Why am I telling you this? Because those are the components of hemoglobin, right? We have our alpha beta chains, right? So you have your heme, okay? You have your globin, and you have your protoporphyrin. So these are the three components. So if you lose any one of these three, then you're not going to be able to make hemoglobin. Then you're not going to be able to make red blood cells. Then you're going to have a microcytic anemia. I just want you to keep that specifically in mind. So if you can't make heme, that's iron deficiency anemia, because heme requires iron. If you can't make globin, that's thalassemia, either alpha or beta, and that's not what we're going to talk about this lecture. Or protoporphyrin, and that's going to be sideroblastic anemia or lead poisoning, but Dr. Rehan did not really focus on these as much as the other two, so just keep that in mind. Okay, now let's go into iron deficiency anemia specifically. It's a hypochromic, meaning MCV less than 80, and microcytic anemia. Okay, so the cells are small and they don't have a lot of hemoglobin. Why? Because like we just said here, you can't make heme, so you can't make hemoglobin. So the amount of hemoglobin in your cell is going to be low, and then you're going to have a central area of pallor. Okay, so this could be due to chronic blood loss. It could also be due to a nutritional deficit. And remember what I showed you guys in the earlier slides, you're going to have increased anisocytosis. So the sizes of the cells are going to be different. So that's going to mean you have a high RDW, and you're going to have poikilocytosis, or the shapes of the cells are going to be different. Specifically, you can see elliptocytes and teardrop cells. Okay. And like we just mentioned, you can't make the cells to begin with. So if you can't make the precursor cells, you can't make the RBCs. So you're going to have a low reticulocyte count. And the important thing to do is test for ferritin levels. I'm going to explain the different types of storage forms of iron in a second. But just the key thing to point out here is you're going to have low serum iron. Okay, there's no iron in the blood, or little iron in the blood. Increased total iron binding capacity. Why? I'll explain that in a second. Decreased transferrin saturation. Okay, and low ferritin. But the important thing is that ferritin is the most sensitive for your iron deficiency. Why is that the case? Because it's the storage form. Okay, and so let's look at this. I took this from one of the Boards and Beyond lectures, but I just liked how he looked at it as an algorithm. So let's say you have loss of iron. The first thing you're going to do is you're going to take what you have stored and you're going to put it into the cells you need. So that's why ferritin is the first thing to decrease. And that's why we're saying here, that's why you want to test for ferritin levels, because it's the first thing that's affected. So if that's affected, then the rest can be affected. Okay. And then you have increased transferrin, or TIBC. Why this increases is your body detects, oh, I don't have enough iron. Maybe I need to make more proteins to bind the iron, right? Because iron is always bound. Okay. And then after that, only after that, does serum iron decrease. And then if serum iron decreases, the percent saturation of iron in your blood decreases. Okay, so I just want you guys to keep in mind that when we say here, test for ferritin levels first, it's because ferritin is the first thing to decrease. So I'll give you an example. Okay, I can't really think of anything. Okay, let's say you're a business, right? Let's say you're a cookie shop, bakery. You have your cookies in the display. Let's say Magnolia Bakery, because that's my favorite. And the cookies finish. The first thing you're going to do isn't going to be thinking about, let's make more cookies. It's going to be, let's check what's in the back, right? Let's check the storage. Maybe we have an extra tray of cookies that we can put in the display. So that's the same principle here. If you lose iron, the first principle is, okay, let's take it out of the storage. What's the storage form? Ferritin. Okay. Only then will you think, as let's say a cookie shop owner, okay, maybe we need to make more cookies. So let's get more trays, مثلا, which would be the transferrin in this case. And then only after that would you decrease your serum iron, decrease your percent saturation. So again, the key thing here is just to remember that you're testing for ferritin, but these are the different lab values that you can see. Yeah, Yusuf, kind of like glucose storage. Okay, what's the reason for the RDW to be high? Okay, so in iron deficiency anemia, remember, this is not a genetic problem. Okay, so the way the hemoglobin is distributed between the cells is going to be different. But in thalassemia, it's a genetic condition. So all of the cells are going to be exactly the same. They're going to have the exact same problem. Okay, so that's why in iron deficiency anemia, you have a lot of anisocytosis. The RDW is high. But in thalassemia, it's low. I hope that makes sense. Okay, and the last thing to know about IDA is that usually when you treat the cause, let's say it's menorrhagia, or the woman is bleeding too much during her period or menstrual cycles, or it's or it's, let's say, from blood loss, or it's a nutritional thing, then the first thing you're going to do is treat the cause of the disease. So if someone comes to you with iron deficiency anemia, let's say because they have cancer, you're not going to tell them, okay, let's give you iron and see if that helps the anemia. That's a horrible practice as a doctor. The first thing you're going to do is fix the problem. So you'll remove the cancer, you'll treat them with chemo, and you'll give them iron as you go along. And so you give them oral iron for 6 to 8 months. Usually that helps. Yeah, and so this is what iron deficiency anemia looks like. So first, it's an anemia where you have less red blood cells than normal. Okay, now you see these cells, they kind of look like a teardrop. So these are teardrop cells. These are elliptocytes because they look like an elliptical, okay, elliptical shape. And you can also see that you have hypochromia. So the central area of pallor is much bigger than it would be in a normal red blood cell. And its sizes are different, so that's anisocytosis. Shapes are different, that's poikilocytosis. So these are all the features you'd see in iron deficiency anemia. Okay, so that's the first part, which is the microcytic anemias. Now we'll move over to macrocytic anemias. So remember, that's when you have MCV greater than 100. And this is what we call megaloblastic anemias, when the causes are B12 and folate deficiencies. So B12, what are the different shapes of? Why are the shapes different in iron deficiency anemia? To be honest, I'm not 100% sure, but I can look it up for you if you want after the lecture. Okay, so sorry, back to megaloblastic anemia. So again, the cause is B12 and folate deficiency. And why would you have these deficiencies? It could be gastrectomy, which is when you remove the stomach, and you guys learned in GI last semester, inshallah, that you have intrinsic factor in the stomach, right? An intrinsic factor is important for binding these vitamins and leading to their absorption. And so if you don't have that because you removed the stomach, which is what we call a gastrectomy, then that can lead to these deficiencies over time. Also, you can see that in chronic alcoholics because they have malnutrition and problems with absorbing the vitamins. And so that's our macrocytic anemia, MCV greater than 100. And the key thing you're going to see in a blood smear is what we call hypersegmented neutrophils, more than 5 lobes. So our problem here, we said in the microcytic anemias, our problem is that we can't make the hemoglobin, right, in the beginning. So that was the problem. But here, there's no problem with hemoglobin. There's no problem with heme. There's no problem with iron. There's no problem with protoporphyrin. Our issue here is that we can't make the DNA, okay? And remember, it's DNA, not RNA. That could come in MCQs. Why is that the case? Due to B12 or folate deficiency. Okay, so just keep that in mind. You have a mature cytoplasm but an immature nucleus, and I'm going to show you that what that looks like. Okay, so in megaloblastic anemia, these cells are much larger than normal. So they're normal chromic. We don't see any in like bigger central area of pallor. Okay, and neutrophils, which is what we said, hypersegmented neutrophils. Here, there's more than 5 lobes. Let's count 1, 2, 3, 4, 5, 6, which is what we're calling a hypersegmented neutrophil, which is, like you said, Judy, if I'm not mistaken, it would be right shift neutrophil. Okay, so this is the main feature we're going to see in a megaloblastic anemia. Okay, is that clear to everyone? Do you guys have any questions? عادي لو احتجتوا شيء I can repeat. Okay. Inshallah, all clear for everyone. Again, after the lecture, if you guys have any specific point, you can always ask me. Okay, so this is megaloblastic anemia. Just to recap, remember, B12 folate deficiency means you can't make DNA, not RNA. You can see hypersegmented neutrophils greater than 5 lobes, and your MCV is greater than 100. Okay, so you have a mature cytoplasm but an immature nucleus because you cannot make the DNA. Next, we move on to aplastic anemia. Okay, so when we say aplastic anemia, it basically means the bone marrow is useless, cannot do anything. You don't have a bone marrow, you don't have the precursor cells to make the cells that you need in everything. It's not just red blood cells, it's not just white blood cells, it's everything. All your cell lines are deficient. And so when all of your cell lines are deficient, you call that pancytopenia. So pan meaning everything, cyto referring to cells, and penia meaning less, right? So you have a deficiency in every single type of cell in the blood. حلو. فthat just means you have low platelets. That means you have low red blood cells, which is anemia, right? That means you have low white blood cells. كله. Okay, so you're going to see all the numbers are going to be low on your CBC. And the problem here is you don't have the stem cells in the first place. The bone marrow is literally empty. You can't do anything about that, right? That's a lack of hematopoietic stem cells. And because you have an empty bone marrow, there's hypocellularity. And when that happens, what you're going to see when you do a bone marrow biopsy is that there's fat infiltration of the bone marrow because it's empty. And unfortunately, it's idiopathic, which means for the most part, we don't know the cause. You have specific genetic syndromes that can have aplastic anemia associated with them. But for the most part, we don't know why this happens. And the only way you can treat it is by a bone marrow transplant for this patient. And so just a note to keep in mind, when you do a bone trephine biopsy, cellularity is tested by bone marrow biopsy. You do 100 minus the patient's age. Let's say if the patient is 50, you'd expect 50% cellularity, and then it decreases as you age. So this is what I wanted to show you guys. So there's less red blood cells. You see maybe one single lymphocyte. Maybe this is like a platelet here, a platelet there, but generally all of your numbers are low of the cells. And this is what we mean when we say there's an empty bone marrow. This is a biopsy of the bone marrow, and you see these white globs everywhere. These are fat cells. So this is fat infiltrating the bone marrow, and this is what we call an aplastic anemia. There's no cure. No, there is a cure. You can do a bone marrow transplant, but generally speaking, we don't know what the cause is. That's why we call it idiopathic. And it just happens, and we are yet to discover why this happens in this specific patient. But yeah, and that's the main treatment for these patients, eventually bone marrow biopsy. So again, all cell lines are low, bone marrow is empty. If you do a biopsy, you're going to see infiltration of fat cells. So this is what we call hypocellularity. You don't really see cells in the bone marrow. Okay, I feel like this is straightforward enough. Do you guys have any questions about aplastic anemia? All good. Again, if you guys have questions, don't be shy. You can always ask. I do. If you want to say in the private chat. How about giving growth factors for cells? Would that help aplastic anemia? That's a good question, Noor. What I want you to keep in mind is that when we're using the growth factors are helping the stem cells convert into different types of cells, into newer types of cells. And when, let's say, in a normal patient that has normal stem cells, that would work. But remember, our problem here is there's a lack of hematopoietic stem cells. The stem cells aren't there in the first place. So even if you give them the growth factors, there's nothing to grow. You get my point? It might help. So I haven't read any papers about that to a certain degree. It could. You never know. Give me 1 second. I'm so sorry that someone is calling me. 1 second. But yeah. Okay, so I'll come back to your question, Josepha, later. Let's just go through this part and then I'll get back to you, okay? So now we finished from the hypoproliferative anemias, which is when you couldn't make the cells in the first place, right? Either you couldn't make the precursors, which is aplastic anemia, or you couldn't make the iron, or you couldn't make the hemoglobin, so you didn't have iron, you didn't have globin, or you didn't have protoporphyrin, or you had increased blood loss over time. So now we move on to hyperproliferative, which is when you're making too many RBCs, okay? And what happens here is you have premature RBC destruction. So this is what we call a hemolytic anemia. So hemo referring to blood, lytic referring to lysis or breaking down. So what happens is you have a normal amount of red blood cells. There's no problem with making them. So the whole beginning process, you have the stem cells, you have the hemoglobin, the heme, the globin, everything is fine. But once the red blood cells leave, there's something that's causing them to be broken down. And once they're broken down or destroyed prematurely, what's going to happen is your bone marrow is going to realize, okay, we don't have enough RBCs. So what are we going to do? We're going to increase the production of our reticulocytes. So you'd expect the reticulocyte count to be high. So I just want you guys to see that the steps make sense. And so why would you have hemolytic anemia in the first place? Why would your body decide to break these down? Well, it could be a hereditary problem, okay? It could be because of thalassemia, because the cells are abnormal, so your body breaks it down. Could be due to sickle cell disease or sickle cell anemia, okay? And it could be due to G6PD deficiency, and this we're going to talk about in a second, okay? Or it could be acquired, which is an autoimmune hemolytic anemia, which is kind of when your body makes antibodies that attack the red blood cells. But I just don't need you guys to know that in detail. I just need you to know that you could be born with it, or you could get it from something, okay? And the three very important signs of hemolytic anemia are, obviously, you have anemia, so that's low hemoglobin and hematocrit for age and gender. Secondly, remember from the signs I showed you earlier, you can have jaundice. And the reason you have jaundice is that you have excess unconjugated bilirubin in the blood, okay? And that unconjugated bilirubin is what causes yellowing of the sclera or the eyes, like I showed you guys a picture of in the beginning, or it could cause yellowing of the skin as well, usually when it gets very advanced. But the important thing here is to remember that you have unconjugated bilirubin in your red blood cells. And in a normal person, red blood cells have a lifespan of 3 months. And then they get broken down, and then the unconjugated bilirubin goes to the liver to become conjugated and then either excreted in bile, or you can excrete it in the feces, and etc., or in the urine. But let's say your liver cannot catch up. It cannot conjugate all this bilirubin because your red blood cells are just exploding everywhere. So what's going to happen? You're going to have increased unconjugated bilirubin in the blood, and that's what's going to cause the clinical manifestation we know as jaundice. And last but not least, we're going to have splenomegaly. So you have excess red blood cell destruction in the spleen, and that's why the spleen becomes enlarged. And we see this in a lot of the hereditary conditions, especially sickle cell and thalassemia and whatnot. Okay. So that's for the hemolytic anemia. And so again, we're going to look at the signs of hemolysis. Signs of destruction. We said high bilirubin, right? Because the liver, I'm sorry. The liver can't metabolize it all. So it becomes unconjugated, and you have increased unconjugated bilirubin in the blood, okay? And this is because of breakdown of the RBCs. Also inside the RBCs, we have LDH or lactate dehydrogenase, and it's also present inside the RBCs. So if you're going to break it open, what's going to happen? It's going to spill into the blood, okay? And last, in terms of signs of destruction, and this is very important and will come in your MCQs, I'm sure of it, is decreased haptoglobin. So what is haptoglobin? Haptoglobin is a molecule that's present in the blood. And what it does is it binds free heme. Okay, so once it binds free heme, this becomes decreased. But let me put it this way, okay? Okay, because this is the closest example I have. Let's say this is your red blood cell. This is a polo, for those of you that like polos. This is your red blood cell, okay? Inside it, we're gonna have our bilirubin. We're gonna have our LDH, okay? And of course, we're gonna have our hemoglobin, okay? So let's say you have a hemolytic anemia. So that means you're going to take this little red blood cell and you're going to destroy it. It's hemolysis, so hemolytic anemia. That means breaking down. Oh my God, if I don't break this, you broke down your RBC. So that means first you release the bilirubin. So you're going to have high unconjugated bilirubin. You release the LDH, you're going to have high LDH. You release the heme, right? Hemoglobin. Hemoglobin is released now. And hemoglobin floating around in the blood is dangerous. So what's your body going to do? It's going to take that hemoglobin and it's going to bind it. It's going to bind it to something called haptoglobin. If you have all of your hemoglobin bound to haptoglobin, the levels of haptoglobin are going to become low. Basically, you're just using it up in order to bind free heme. So thus it's decreased. So just always remember, low haptoglobin means you have a hemolytic anemia because of increased release of heme in the blood. Sorry, that was a mouthful, but inshallah that makes sense. Okay, so those are the signs of destruction. Signs of production is basically going to be your bone marrow compensating. There's nothing wrong with the bone marrow. So it's going to say you have low red blood cells. Yalla, let's make more. Yalla, let's make more. So you're going to have increased reticulocytes. Okay, and you're going to have nucleated RBCs in the blood. Why would you have nucleated RBCs? The body is just trying to speed up the whole process of your RBCs becoming normal, right? Because first they're nucleated and then they become enucleated and they become normal RBCs. So does that make sense? Because this whole process is super important for you guys to know. I can repeat the hemolytic process if you need me to do so. على بال ما تردوا حق للفولو. Okay. Are you guys sure it's clear? I can repeat it again if you need me to. Thanks. I don't know. I made a random grocery store trip and my sister bought like a whole box of polo, so I'm gonna be eating these. Okay. Quick review. Okay, just to quickly review. Yeah, I'll repeat it. Don't worry about it. Just close it polo so it don't sound annoying. Okay. So in hyperproliferative anemias, you're making something extra, you know? So you're hyperproliferating, you're making a lot more. Okay? So I'll give you guys an analogy of the cookie shop again. So let's say you're in a cookie shop, right? وفتحته في رياض season. رحت البوليفارد. You realize that people are destroying your cookies. Everyone is destroying in a good way. Hello, everyone is eating the cookies. So what's your response going to be? It's going to be, okay, let's make more cookies so I can sell more, so I can make more money, right? So that's the same principle as a hyperproliferative anemia. There's something being destroyed, so you're just going to make more of it in order to keep the supply up. Although it's in a positive context with cookies, it's going to be in a negative context with anemia. So what happens is you have premature destruction of the RBCs. Normally, our red blood cells live for 3 months and then khalas, we break them down and we make new ones. And there's a reason here, something could be causing it to be broken down earlier than normal, which is what we call premature destruction. Either you're born with it, meaning it's hereditary, or it's acquired. If you're born with it, it could be thalassemia, sickle cell, G6PD, which I'll explain in a second, or it could be acquired, such as immune hemolytic anemia, and that you guys are going to learn about inshallah in third year. So now, the 3 very important signs of hemolytic anemia. As the name suggests, anemia. Secondly, jaundice because of increased unconjugated bilirubin, and splenomegaly. So these are the 3, the triad or the 3 things you need to know that come together. By then, signs of hemolysis, you have signs of destruction and signs of increased production, right? So destruction, remember, in your red blood cell, you have your LDH, okay? You have your bilirubin, and of course, you have your hemoglobin. If you're going to break this down, hemolytic anemia, right? Hemolysis, so انكسرت, you're going to release these into the blood. These 3 being, first of all, bilirubin. Because it's being released so much, your liver doesn't have enough time to conjugate it. So it's high unconjugated bilirubin. You're going to have increased LDH, okay, because it's just simply spilled out into the blood. And once you release your hemoglobin, heme is going to be bound to something called haptoglobin. فلو haptoglobin جا مسك الهيم من هنا ومسك الهيم من هنا ومسك الهيم من هنا, what's going to happen? The levels of haptoglobin are going to be decreased. So just again, keep that in mind. And lastly, signs of production, like the cookie example I gave you guys. If something is being broken down, you're just going to start making more of it in order to keep up with the supply, the demand, sorry, for your supply. And so that's going to manifest in the body by increased reticulocyte count and having nucleated RBCs in the blood. والله صراحة I'm not ignoring. I'm sorry. This, yeah. So I hope that was just brush over everything. Now let's move on to G6PD deficiency. Okay, so G6PD deficiency is actually very common in our Mediterranean Arab region, and one of my friends actually has G6PD deficiency. So what basically happens is you have an oxidant in the blood, drug fava beans, fava beans, which is يعني فول, تميسو فول, you know, my Hijazi family out there. Always the best thing to eat, خصوصا حين Ramadan. But sadly, when these people eat fava beans, what's going to happen is this oxidant is going to cause free radicals in the body, specifically in the red blood cells. And these free radicals are going to attack the bonds between heme and globin. Obviously, we need our hemoglobin to be together so it can work, so it can bind oxygen and go everywhere. And so because of G6PD deficiency, the body cannot basically, you don't have enough antioxidants to fix these free radicals, because they're attacking the bonds. And so what happens is once you break down heme and globin, the globin chains, okay, since I already broke this polo. So let's say we have heme and globin and we broke them down. What's going to happen is, probably not the best example, but the globin chains are just going to stick together. They're going to precipitate. And that's going to form something called a Heinz body that we see with a supravital stain, which is what we also use, as you guys pointed out, to detect your reticulocytes. So you're going to see Heinz bodies and you're going to see bite cells. Bite cells literally looks like you just took a cookie and took a bite out of it. And I'll show you guys what that looks like in a second. And so the globin is going to precipitate, which forms the Heinz body. And then the heme is going to be released into the blood. And from the same principle we talked about, heme in the blood is going to be bound by haptoglobin, which means haptoglobin is also going to be low, which makes sense because we said in G6PD is a hemolytic anemia. صح? So patient is going to present with our triad of hemolytic anemia, which is what? Jaundice, obviously anemia, and splenomegaly. Our big three. And so also what you're going to see is Heinz bodies and bite cells in peripheral blood smear. And so levels of G6PD will be elevated during an acute hemolytic episode. So let's say عندك محمد. Okay, محمد للأسف has G6PD deficiency. But he didn't know it. Okay, جاء يوم الجمعة على الفطور وأكل فول. He had fava beans. Okay, he had fava beans, and then soon after that he started he had tachycardia, or his heart started beating. Suddenly his eyes turned yellow, and he was in a lot of pain. He was very confused. He had shortness of breath and he didn't know what was going on. So he went to the hospital. They took a CBC. They discovered that Muhammad has anemia. They did a blood smear and they did a supravital stain لأن الدكاترة شاطرين. Or they took reticulocytes. They said reticulocytes are high. حلو. They said this patient has a normocytic normochromic anemia. Okay, and when they did the supravital stain, they saw Heinz bodies. So that led the doctors to conclude that Muhammad has G6PD deficiency and that he should not eat food on any day. Okay. Okay, so last point here is if levels of heme exceed haptoglobin levels. So we said صح, this is the heme وهaptoglobin قاعد يمسك من هنا ويمسك من هنا ويمسك من هنا. It's going to be low. But let's say the breakdown is so high that hemoglobin خلاص صفر ما في. What's gonna happen? You're gonna get hemoglobin in the urine, which is hemoglobinuria. Okay. Um, and so, like I said, the way you treat these patients for Muhammad is by avoiding oxidants and blood transfusions. And let's say if they reacted to a specific drug, usually things like sulfa drugs, then you just avoid them. So remember how I told you it's called a bite cell? Look at this. It literally looks like you just took a bite out of it. This one just took a bite out of the RBC. So for those of you that like ketchup, I absolutely hate ketchup. But there was a mnemonic in Ambos that's like, think of it as like you took a bite out of your Heinz ketchup. So you remember that like G6PD deficiency. And these, do you see these with a supervital stain? These are what we call the Heinz bodies. Okay, so these are our Heinz bodies and these are our bite cells. Okay, and now I promise you this is the last slide before we get to solving questions. So last but not least, we have something called hereditary spherocytosis. So as the name suggests, it's hereditary. So you're born with it. Spherocytosis. So sphere meaning like, yeah, like a circle. حلو. And cytosis referring to the cells and, condition of cells that look like this, like stress balls. Okay, so what happens is you have defective spectrin, which is a specific protein on the cell surface. Okay, and that leads to unstable red blood cell membranes. We know the red blood cells are, this is the third polo I opened, بس يعني لسه ما أعرف واحدة. Red blood cells are like the polo, صح? They're a flat biconcave disc that allow them to slip through capillaries and have no problems. But if you have this deficiency in spectrin or defective spectrin, what's going to happen is instead of looking flat like our polos at Halloween, they're going to look like a stress ball. And so this is a very unstable cell. And the problem with this is that they get broken down by macrophages in the spleen. Okay, but we'd suspect that the patient has a big spleen now because it's working a lot. So they'd have splenomegaly. And in severe cases, you might perform splenectomy, which is removal of the spleen, because basically the spleen is just causing the breakdown of all of these red blood cells. And so if you remove the spleen, you prevent the breakdown of red blood cells. You get me? So this is what it looks like. You see how these cells have barely any area of central pallor aslan? They just look like stress balls, Not all cells, but most of them. So this is what we call hereditary spherocytosis. Okay. Someone asked a question. Spectrum for both spherocytosis. I believe it's in your physio lecture. صراحة I'm not 100% sure. خلاص بعد لكم ما عليكم. بس أسيل سألتيني false reading in the G6PD slide. So G6PD levels بدون شيء are high in reticulocytes. So if the patient came very late and had a very high amount of reticulocytes, this might cause a false reading of G6PD levels. That's what this is trying to say. Okay, for hereditary spherocytosis, you have defective spectrin, okay, which is a protein on the cell membrane that causes its shape to be like this. We know how does a red blood cell look like? It's a biconcave disc, ملفوفة من تحت وملفوفة من فوق. صح? So if you have a defective spectrin, it doesn't look like a disc anymore. It's gonna expand out, kind of like a bubble. Okay, so it's gonna look like a stress ball. بدل ما تكون flat حتكون مدورة زيادة. Okay, and so because of the instability in the RBC membranes, they're gonna form spherocytes. And because these spherocytes are unstable, the spleen is gonna look at them and say, okay, these cells are bad, these cells are abnormal. So they're gonna come and they're gonna break them down. Okay, so they're gonna break down these cells again and again and again. That's what hereditary spherocytosis is. Okay, but the thing is, let's say this patient has very severe hereditary spherocytosis. We said the problem is the spleen is breaking it down. What we can do is remove the spleen to stop the breakdown of the red blood cells. So that's why we're saying here in very severe cases, splenectomy is performed to prevent RBC destruction. خلاص, you figured out the... Aren't they both? both spectrin and anchorin. شوفوا لو جاكم MCQ Dr. Rahan is putting most of the MCQ, so I would say these slides I used for PAL when I was in first year. I was giving like this exact same lecture, and again I took this from Dr. Rahan's slides. He said spectrum. فلو حسيت your question is physio related, go for that. But what you can always do is appeal the question. Okay. Okay, in terms of numbers as an MCV and stuff, what would be the finding in this? It should be normochromic normocytic. It says right here. So normochromic would be within the reference range, I believe 26 to 34. I'll double check, it's on the slides. A normocytic, so it would be within 80 to 100. Okay, خلاص, stick to what your slides say يعني. But as for the diseases and everything, تراني خلصت, okay? I have a lot of questions after for those of you who want to stay and solve with me. But I will give you guys, so there isn't any dysfunctionality in this disease. There isn't any dysfunctionality with the red blood cells precursors or the hemoglobin or the and you're destroying the RBCs because the shape of them is abnormal. That's the whole point. Like the red blood cells are not normal because their shape is weird. So your your spleen looks at it and it's like, okay, this is weird. I'm gonna break it down. But if it's very severe, then your spleen is gonna keep breaking it down again and again and again and again and again. So your solution would be just remove the spleen. And then usually these patients will do well after splenectomy. I hope that makes sense. But other than that, you guys, if you have any questions, feel free to let me know. What I want to do is I want to give you guys a 7-minute break. Would that work? If we come back at like, well, 6 minutes, we can come back at 10:50 and discuss everything. Oh, thank you, Reem. That's very sweet. Wait, you guys have a question? Wouldn't these cells get caught in smaller capillaries? It's not as bad. Like you're thinking of it in terms of sickle cell anemia. You know, sickle cells, their shapes are weird. They can squeeze through, but they might burst, from what I understand. What about the SAQ? Do you know what lecturers will be involved? Did you have any idea? Okay, Judy, صراحة I don't. But as we go through the questions, I'll give you a bit more anecdotal advice and what not to do. I remember I'm 11th batch, so for our HLS exam, we had, what was it? There was a question, there was biochem, I remember something biochemish, or was that our biochem? I'm not sure, but it was, I'll try to open the exam and find it. But we had, I believe, thalassemia, and we had leukemia, like increased breakdown. And then what do you do? I'll find حكاية لو I just say الحين. Okay, so guys, we're gonna be back in give or take 5 minutes. Ovalocytosis, part of hereditary. شوفي أنا صراحة I've never heard of ovalocytosis, but since you guys are here, I will Google it for you. But I really don't know what that is. Like I know spherocytosis is. I mean, are they just ovals? Is that elliptocytosis? I think. Yeah, hereditary elliptocytosis is ovalocytosis. They're the same thing. So they just kind of look كذا, like an oval, instead of ovalocytosis causes. Oh, there was one important thing that you guys should know, so I'll add it now. Thank you, Hamza. That was very sweet. I'm glad you guys enjoyed the lecture. And I'm glad I had polo nearby. This what I want to find. Okay. Okay. Plus, whenever you guys are ready, you want to start the MCQs, let me know. If you guys want a longer break, let me know. عادي. Okay, everyone's all good? Like, just before we start, there was one thing that I made a mistake in. Or I didn't make a mistake in, I just didn't mention it, and I should because it could come in MCQs. Just remember with hereditary sphere, or actually, I'll go to G6PD first. Remember, G6PD is X-linked recessive, meaning it's more common in males, right? Because males are XY and females are XX. And since it's recessive, males only need one X for it to happen. So just keep that in mind and know G6PD deficiency is more common in males specifically. So they could get that in a question. Okay, and within they could get you the triad that we talked about, splenomegaly, anemia, and jaundice. And then they said, within this is a 25-year-old male that ate fava beans, then your mind jumps to G6PD deficiency. But they could ask you within what's the mode of inheritance. You would say it's X-linked recessive. Okay. And the kid, they already mentioned that. I just wanted to make sure to mention it here because it can come in MCQs. But hereditary spherocytosis is autosomal dominant. So it doesn't matter what gender the person is. They could get you a girl in the vignette, they could get you a boy in the vignette, doesn't matter. But just to keep that in mind. And they would say, for example, oh, their father had a similar condition. Their uncle, just keep that in mind. So hereditary spherocytosis is autosomal dominant. G6PD deficiency is X-linked recessive. And you guys already know like sickle cell anemia and thalassemias are recessive, autosomal recessive. But just to keep that in mind for later. So now what we're going to do is, I'm going to sneeze one. Sneeze went away. Anyway, so what we're gonna do is we're going to look at these different blood smears, and then you're gonna tell me if you see anything abnormal. So I want you guys just to write in the chat, what do you think this is? Could be a trick question. You never know. Okay, but wait, let me add one thing. This patient is 21-year-old female. Okay, hemoglobin was 13, MCV was 88, MCH was 30. These are all normal. Hello? And the patient was coming for a routine checkup and had no symptoms. So, yep, this is a normal adult female. Okay, so just again, keep that in mind. They could get that as a trick question and just know that this is normal. You don't see any abnormal shapes. It's not spherocytosis because you do see the central area of pallor in all of these. And remember, if I told you it was a male, then you would say, oh, they have a normocytic anemia because the hemoglobin is 13. But since it's a female, then remember hemoglobin 13 is normal. Right? So now I gave you this. The patient was a 70-year-old male that came presenting with fatigue, had hemoglobin of 9.7, which is low, MCV of 69.7, FL, which is low, and MCH of 22.3 picograms. So tell me what you guys see in the blood smear. Exactly. It's microcytic hypochromic. Microcytic meaning the size of the cells is low, we know by the MCV. Hypochromic meaning there's bigger central area of pallor. You can also see kind of here what we call target signs, not super clear. You can see anisocytosis. The sizes are different. You can see, this looks like a teardrop cell. You'll probably see elliptocytes. So this is iron deficiency anemia. Okay, you guys all got it. And so again, in this scenario, because I told you guys it's like a 70-year-old male presenting with fatigue, then if they ask you what's possible cause, it could be colon cancer or bleeding. Okay. Now this one, a woman presents 2 years after having a bariatric surgery, which is gastrectomy. And once they did a CBC, this is what they found. They found hemoglobin to be very low, 6.5 grams per deciliter, MCV to be 113, and MCH to be 26. So what type of anemia do you guys think this is? Yep. Exactly. Okay, so this is a macrocytic normochromic anemia. Okay, first of all, it's anemia because she's a female and it's low for her age and gender. MCV is 113, which is high, remember 100. And MCH is 26, which is normal. Okay, so this is what we call megaloblastic anemia. Because I told you in the scenario, she had bariatric surgery, which means she had a gastrectomy, stomach was removed. And because of that, most likely she lost her intrinsic factor, so then she lost her B12 ability to absorb that, and so she has a megaloblastic anemia. Microcytic. Yes, Reem, for your question, is there such a thing as microcytic hypochromia? We call it microcytic hypochromic anemia, which is what we saw on the previous slide, like iron deficiency, anemia, and you also see that in thalassemia. Hey, don't worry, I'll send you guys a PowerPoint. I'll just add the autosomal dominant recessive thing that I told you about. Okay, and so again, this is the same patient as the last slide. And I just wanted to point out that even though here you don't see a hypersegmented neutrophil, it does not mean that this isn't a megaloblastic anemia. Hello? But if they do get it in the OSPE, for example, what you'll see is something like this. Okay? So you can count the lobes, hypersegmented or right shift neutrophil. 1, 2, 3, 4, 5, 6, 7, 8. So more than 5 is what we would see in a megaloblastic anemia. All right? And this is the same one, okay? Okay, now يلا نفس السcenario, so you guys remember it. Muhammad is a 25-year-old male that went to Futur in Ramadan on a Friday with his family and then presented with anemia, splenomegaly, and jaundice. Now, exactly, so you see bite cells, so it's G6PD deficiency. That's not going to be my question, even though, okay, this is the labs. We identified that it's G6PD deficiency. I'm going to tell you one of the lab values. You're going to tell me if it's increased or decreased. حلو. LDH. High. Yes. Okay. Other than LDH, we have haptoglobin. Reticulocytes. Okay, now unconjugated bilirubin. خلاص ممتازين خلاص بس. HLS is in the bag إن شاء الله ما عليكم. So yeah, G6PD labs, you're gonna have increased LDH. Remember the polo اللي كسرتها. Increased LDH. You're gonna have decreased haptoglobin. You're gonna have increased unconjugated bilirubin, and you're gonna have increased reticulocytes. Okay, so greater than 2%. And these are the bite cells. Okay, and if they give you this smear and you're like, I see Heinz bodies, no, you don't. You need to do the supravital stain. Okay. Okay. You're asking if there's such a thing as macrocytic hypochromic. I haven't seen that صراحة. But I can look it up if you want me to check. Okay, so why reticulocyte count is high? So Rishdan, this is a hemolytic anemia, meaning you're breaking down the red blood cells because they have a G6PD deficiency. Okay, so what happens is the RBCs are being destroyed. So your bone marrow sees that there are low RBCs. So what's it going to do? It's going to start to produce more. And when it produces more, the bone doesn't just pump out red blood cells على طول. There's a process to it. First, you get reticulocytes, and then you're going to get your nucleated RBCs, then your enucleated RBCs, and then they become normal. So they're just like pumping out the precursor cells. That's why your reticulocytes are high, okay, which is what we would call polychromasia. I hope that makes sense. Okay, so now you see this patient presents with splenomegaly, new onset of jaundice. Patient is 17-year-old female, and she mentions that her father has similar symptoms. What do you suspect? HS. Okay. Yep. You guys got it. So this is hereditary spherocytosis. Do you see how there isn't like the central ring of pallor? Like it's not that prominent in a lot of the red blood cells. You can like 1 or 2 compared to the rest. But that tells you that it's kind of like a circle and it's not dipped in the inside, which is why you don't have that central area of pallor. Yes, and you need a splenectomy if symptoms are very severe. صح عليكي. Okay, so again, just to recap, this is what iron deficiency looks like. This is what megaloblastic anemia looks like. This is G6PD deficiency, and this is hereditary spherocytosis. Pardon? Just to recap. So now that you guys know what everything looks like, now we're going to go through actual questions, so you'll be able to identify these pictures better. And يعطيهم العافية, as always, academic aid. I took all the questions from them. I just want to make sure you guys see it first. Okay, اهدوا شوي قبل ما نجاوب على الأسئلة. Let's take a breather and let's read the question first together. Okay, because I want to make sure you know the important things here. Okay, a 10-month-old boy of Arabic extraction, that's a really weird way of saying it, but of, Middle Eastern descent, okay, is brought to the physician by his parents who complain that their child is failing to thrive, meaning he's not growing properly, okay? Physical examination reveals splenomegaly and jaundice. CBC shows a microcytic hypochromic anemia. Okay, before I even continue, we found our triad, صح? Our triad of what? Hemolytic anemia, which is anemia, splenomegaly, jaundice. Okay, so we know this is hemolytic, bila shak, okay? Now, fetal hemoglobin accounts for most of the hemoglobin, okay, because there's fetal, adult, but I'm not going to go into those details. A peripheral blood smear is shown in the image. Which of the following is the appropriate diagnosis? Okay, G6PD, hereditary elliptocytosis, hereditary spherocytosis, iron deficiency, or beta thalassemia. دحين, before we answer, I want you guys to make sure that you guys don't make the mistake that I made in my HLS exam, which is we had a clinical scenario, like an SAQ, that was similar to this question. وأنا جيت اتشطرت I saw the blood smear وشفت ال teardrop cells قلت بلا شك this is iron deficiency anemia. But what I failed to realize is that this is a 10-month-old boy, okay? And because this patient is so young, it's not as likely that in an exam they will get you a scenario of like a young patient that has iron deficiency anemia. So what I want you guys to keep in mind always, and for those of you who are with me in pre-med, I told you, يعني, if the patient is young, most likely it's a genetic cause. حلو? But what we know is that the anemia is microcytic hypochromic. If it's microcytic hypochromic, A, B, C, and these three are not options because these are normocytic, normochromic. So immediately we can eliminate them. But the trick here is between iron deficiency and beta thalassemia. Okay, and so because it's a microcytic hypochromic anemia in a 10-month-old boy, the answer is actually beta thalassemia, not iron deficiency. Hello, I just want you guys to keep that in mind because I will never forget this was the mistake I made in my SAQ. Okay, but please don't make the same mistake I did. Okay, even if you see the blood smear, even if everything is pointing you to that, just keep in mind and know. Because a 6-month-old baby with iron deficiency doesn't really make sense. You know, like why would they be giving you that as a scenario in your exam? You get me? Yeah, that was the first question. Hello. And again, I'm gonna send you guys the slides, and under each one there's explanation for the questions. And I took these from the academic aid. You guys can open the PDF. They're the exact same questions. Hello. I just wanted to solve them with you. Okay. Yeah, the next one. This one's a recall question. Peripheral blood smear of a patient shows polychromasia with 10% reticulocytes. The patient most likely has which of the following hematologic diseases? So we know if you have high reticulocytes, this is a hyperproliferative anemia. صح? So you're making more reticulocytes. Anemia of chronic renal failure, قلنا ما هي hyperproliferative. أصلاً in this case, you don't have EPO or erythropoietin, so you can't really make RBCs. Aplastic anemia ما في precursors أصلاً عشان we say there's 10% reticulocytes. Remember, the bone marrow is empty. Iron deficiency anemia, يعني you won't have this degree of polychromasia. ولا myelocytic anemia, that's something that you guys, I don't think, took yet. But the answer is hemolytic anemia. Okay, remember? So we get an increased number of reticulocytes. This one was recall. Okay. So now we have this question next. 30-year-old woman complains of recent easy fatigability, bruising, and recurrent throat infection. Okay, physical examination reveals numerous petechiae. Okay, the bleeding causes the petechiae to appear red-brown. Okay, we'll ignore that. Over her body and mouth. Okay, so basically what they're saying is this patient has easy fatigability. Remember, fatigue was one of the signs of anemia because they're always tired. Their heart starts beating faster because there's not enough oxygen in the body. They get tired very easily. But now she has two different things: bruising with little like bleeding spots on her legs and body and mouth. Okay, and recurrent infections. So this tells you that you have different cell lines that are affected. It's not just her fatigue. Okay, she has fatigue, which is coming from the anemia, RBCs, bruising, which is from low platelets, okay, and recurrent throat infections, meaning she does not have enough white blood cells to fight off her infections because they're recurrent, they keep coming back. So we did a CBC, it showed her hemoglobin of 6, which is super low, WBCs of 1,500, remember the lower limit is, if I'm not mistaken, 6,000, and platelets of 20,000. Platelets that are normal is like 150,000 to 400,000. So this is very, very low. So like you guys correctly said, this is pancytopenia. And then they still wanted to drill it in more. So they told you the bone marrow is hypocellular and displays increased fat. What is the appropriate diagnosis? In this case, aplastic anemia. Hello, what would you suspect to see? Again, bone marrow is hypocellular and displays increased fat. So remember, when you have aplastic anemia, all of your cell lines are down. Okay? If it was the other anemias, they would tell you symptoms that are more specific to red blood cells. Patient has shortness of breath, high heart rate, gets tired very easily. But in these two, you wouldn't really expect her to bleed easily, مثلا, or to have recurrent infections. And the white blood cells ما لهم دخل, the platelets ما لهم دخل. So that's why this is the key thing here, okay? And so remember, this is what aplastic anemia looks like. You get hypocellularity of all of the types of cells, and you have an empty bone marrow. So if they get you a picture in the OSPE, just remember that this is aplastic anemia. And if they ask in MCQs, what's the most likely cause? We don't know. It's idiopathic. Okay. Now on to the next question. Patient with history of chronic alcoholism, okay, with a macrocytic anemia and thrombocytopenia. Blood smear examination demonstrates numerous oval macrocytes and hypersegmented neutrophils. A Schilling test is normal. Which of the following is the most likely deficiency or diagnosis? Okay. Just so you guys know, Schilling test is when you're testing for the B12 absorption. So if it's not B12 absorption, also it's not in the options. What's the most likely cause? You guys are correct, folic acid, which is going to cause a megaloblastic anemia. Yes, and the reason this patient has a folic acid deficiency is nutritional because this patient is a chronic alcoholic, so they're not able to have proper nutrition or absorption. Okay, and remember these are the hypersegmented neutrophils. حتى في أكثر من واحدة. يلا عد 1, 2, 3, 4, 5, 6. More than 5 is a hypersegmented neutrophil on the lobes. هذه the 1, 2, 3, 4, 5, 6, 7. Okay, I'll repeat this question, don't worry. So patient is a chronic alcoholic, presents with a macrocytic anemia and thrombocytopenia. Blood smear examination demonstrates numerous oval macrocytes and hypersegmented neutrophils. Schilling test is normal. Which of the following is the most likely diagnosis? Okay, so they already told you this patient has a megaloblastic anemia. صح? Macrocytic. Okay, and so what are the two causes of macrocytic? Either folic acid or vitamin B12 deficiency. So if you're just looking at the options, easy way to eliminate is there's a folic acid deficiency. خلاص, this is the answer. Okay, by saying a Schilling test is normal, that's just telling you that vitamin B12 levels are normal. That's just part of the question. You guys aren't required to know that. Okay. What I was doing here, the blood smears, I was just counting the lobes. Just so you guys remember, hypersegmented neutrophil is more than 5 lobes. Again, another question that could get you in MCQs is just remember that this is a problem with the DNA, not the RNA. Okay, so megaloblastic, vitamin B12 or folate. You see it in chronic alcoholics. You can see it in patients who underwent a gastrectomy. Uh, problem with DNA and RNA. That's what you guys need to know from this MCQ. So now we move on to the next one. 25-year-old woman with a history of heavy menstrual periods complains of chronic fatigue. Examination of a peripheral blood smear suggests iron deficiency anemia, which is shown in the image. So they already gave you the diagnosis. They told you she is 25-year-old, has heavy menstrual bleeding or menorrhagia. That's why she has an iron deficiency anemia. Okay, so that means they don't want you to diagnose it. They want to find something else in your knowledge. Which of the following terms appropriately describes the morphology of the patient's erythrocytes? Okay, so we know it's microcytic, hypochromic. We have a lot of anisocytosis and we have a lot of poikilocytosis. Okay, but the important thing to know is that we're talking about the morphology. Okay, morphology is what? The shape, right? So shape, what it's basically asking in a different way, very complicated way. How do you say in medical terms different shapes? Poikilocytosis, صح? So that's why the answer is, you guys are correct. It's A. Okay. So just to review, you have hyperchromic, which means increased color or density, and we usually see this with our reticulocytes. Remember, polychromasia. Macrocytic means it's big. Microcytic means it's small. Normocytic means it's normal. Okay. And poikilocytic means they have different shapes, which is what they're asking about for the morphology. Okay. And what are the shapes we see in iron deficiency anemia? We see elliptocytes, we see teardrop cells, and yeah. Are there hyperchromic RBCs? Usually they're normochromic, from what I saw. Meaning حتى megaloblastic anemia is normochromic, not hyperchromic. So yeah, like William said, they would most likely explode. Okay. Now, patient walks into the clinic. RDW is around 14.5%. Okay, so RDW is high. Keep that in mind. Okay, the following image shows the blood smear obtained. What is the patient's most likely diagnosis? So you have aplastic anemia, hemolytic anemia, iron deficiency anemia, and thalassemia. Okay. Now, what I want you guys to remember is make mistakes now. It's okay. You're learning. It's not a bad thing. I know we are always too harsh on ourselves as med students when we make mistakes, but it's okay. You're learning from it. And if you get something wrong, you are much more likely to remember that biologically. So keep that in mind too. Okay, so what do we see? We see, first of all, there's an area of central pallor, which tells us this is a hypochromic anemia. And the cells kind of look small, but we need to get the MCV and the MCH, right? So now there's different shapes, right? We can see this teardrop cell. This probably looks like an elliptocyte here. So we see a lot of anisocytosis. So that tells us that this is most likely an iron deficiency anemia because the RDW is high. Remember, in beta thalassemia, or alpha, but mostly beta is what they have as an example here, RDW is very low because all of the cells genetically have the exact same problem, every single one of them. So they're all going to look tiny, 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 and they're all going to look the same. Okay, so there isn't a difference in the sizes. Okay, which is why the RDW is low here, but there's a big difference in the sizes here, which is why it's most likely iron deficiency anemia. What's the normal percent for RDW? Let me check for you, but it's in my slides. I didn't memorize them, but this is high. RDW, here we go. A normal is 12 to 13.5. So hers was 14.5. So it was very high. Okay, so 14.5 was very high. Easy? Do you guys have any questions so far? this is the end of the lecture, end of the MCQs. If you guys want to know anything, if you guys have any questions about HLS, يعني أنا موجودة. Thank you guys for attending. Inshallah, I didn't take too long. I hope it was helpful that this summed up both lectures. ويا يعطيكم العافية. بالعكس أهلا وسهلا. Okay, one of the students asked me for a bit of advice in HLS and time management وكذا. شوف, I'll be honest, there's a lot of med school is going to be giving up your time for others. And I know, خصوصا مع HLS, a big problem we all have is that there isn't enough time for it because you guys have midterms and then فجأة you have mole and then فجأة you have the final وما عندكم إن to breathe حتى and then suddenly it's like, okay, يلا you have a final exam. And we did try to like space out the finals as much as possible ويعني نقول الحمد لله صراحة إن كان عندكم إجازة. Because I hope, you know, you guys got to study for more properly. And honestly, it's just about scheduling your day and being very intentional about what you want to do in a specific day and not being too hard on yourself. And remember that you guys are not machines. You can't study 24/7, even if you want to. You're going to burn yourselves out. Go see your family, حتى if it's like 30 minutes. Go sit downstairs في الجلسة معاهم. FaceTime someone you love. Play a game. Go make yourself some coffee and عادي. It's okay to take time to breathe. And although it feels like you're falling behind when you do that, keep in mind that this is what's keeping you sane so you can keep moving forward. Even if you don't feel like you're at the same pace as other people, it's fine. So I guess that's my final word to you guys. Oh, you guys have another question? Yeah, sure. Okay, can I repeat the part about poikilocytosis? Okay. Poikilocytosis. Okay, so let's just ignore the question for now. Let's just look at the definition. Okay, hyperchromic is basically polychromasia, what we refer to when we talk about reticulocytes. صح? Macrocytic means the cells are large. Microcytic means the cells are small. Normocytic means the cells are normal. So remember, normal is 80 to 100. Less is macrocytic. Less is microcytic. Sorry, more is macrocytic. Okay. When we say poikilocytosis, okay, it means that the shapes of these red blood cells are different. Okay, so poikilocytosis is different shapes. Okay, anisocytosis means different sizes. Okay, so when they're asking you to describe the morphology of the patient's erythrocytes, they're asking you to describe the shape of the erythrocytes. Okay, so the shape is different. They have different shapes, which is why we said it's poikilocytic. Okay, or that's what I would say. وياكم يا رب. I really hope it was helpful. And if you guys have any questions or you need anything, feel free to email me. أنا موجودة. Yeah, you guys got this, inshallah. Yani Dr. Raihan is honestly one of the best professors. And يعطي العافية, he's always super helpful with the students. And inshallah, you guys are going to have a good exam and enjoy. You got this. Okay? And you guys can stop recording whenever you'd like. I think we're all done here.